Dr. Oh, there he is. Hey, Adam, how you doing?
Good, good. How are you?
Great, fantastic. Well, listen, I want to get right to the meat of this. We have participants that are now joining like mad. This is great. We'll give maybe 30 seconds for them to do this. All right. All right, so why don't we get started? Let me introduce to you all. You know, we're obviously in this unprecedented situation of wanting to learn about influenza and infectious diseases as surgeons. Obviously, this has been an extraordinary set of circumstances that has transformed the work that we are doing on a daily basis and the work that we might be called upon to do. Dr. Adam Cifu from the Department of Medicine, who is one of our associate deans, and I can't even remember your title in that regard, but one of the most extraordinary and popular faculty members in the entire medical center. He's a great author, he's a great lecturer, and he's an outstanding clinician. And he offered to help educate us on some tips and give us some good context for seeing patients with ILIs and with COVID-19. So I will turn it over to you, Adam, and hopefully we'll have some time at the end to get some chat questions in. Adam, thanks so much for doing this.
Great, terrific. Thank you very much for giving me the time. So this is a talk that I put together with my colleagues Diane Alcorn and Amber Pinkevich. We've been giving it to the Department of Medicine for the last couple of weeks, sort of revising it practically daily, and now broadening it out. And the hope is just to give some background about what we've been doing, seeing these patients in the outpatient setting, a little bit about seeing the patients in the inpatient setting, and getting comfortable with this. A lot of this stuff you guys will already know. As I talk about putting on PPE to surgeons, I'm going to feel ridiculous, but I'm going to bring you through sort of the general teaching that we've been doing with everybody, and then certainly open it up to questions at the end. So let me see if I can advance here. Here we go. So the objective of this is to get everybody up to speed for caring for patients with ILI, influenza-like illness, or COVID-19 in the outpatient settings. And that may be anywhere. It may be urgent care, you know, it may be in a specialty clinic, it may be seeing people in a surgical clinic, or it may even be seeing people who show up for surgery but are ill. Teach you how to do that safely. We're going to review PPE, how to do it efficiently. I'm actually going to take you through some of the EPIC tools that have been built for this, a lot of the Agile MD pathways, and then talk a little bit about, you know, what we know about the disease, how we make decisions about admissions, and a little bit on what's going on the hospital side as far as caring for these patients. So first of all, when we talk about seeing these patients, the most important thing is to try to limit seeing the patients. So I know we're already all doing this, and this will continue. So limiting face-to-face visits as much as possible, you know, doing phone calls, using e-visits whenever possible. EPIC has come a huge distance recently, so we can really do these now and bill for them using smart sets on EPIC. I can show you a couple of those directions at the end if need be. There are tip sheets available for this on the intranet. I'm sure you already know this. If you have patients who are just seeking COVID testing, the two ways to route those patients through very easily is if they have My Chart, they can open My Chart and answer a questionnaire and get put onto the pathway for the curbside testing, or they can call 702-2800 and access testing in that way. So definitions, just what we're using. So extended use for PPE is wearing the same gear for repeated contact with different patients without removing. Universal masking, wearing masks continuously, and reuse, removing, cleaning, and storing for future use, just when I use these terms as we go forward. Eye protection, we're right now at a reuse stage. So anytime your eye protection is visibly soiled, hard to see through, take it off, disinfect it. You can use any of the purple or orange wipes that are everywhere these days, and then store the goggles or glasses for future use. Obviously, if they're damaged, can't see through them even with cleaning, throw them away. And the pappers, including the lens cuff, should be disinfected and reused. Mask, we've moved to universal masking, meaning that you should wear a cloth mask all the time. Those are basically considered clothing, so you take those home and wash those every night. There to protect patients and staff from us, allowing us to work and not be worried that maybe we have preclinical infection, which we're going to spread. When you're switching to seeing a patient who has COVID or has an influenza-like illness, you should then switch to a surgical mask and keep that on after you finish seeing the patient. You can then wear that continuously. Discard that mask after you have to take it off, eat, drink, whatever, or if it's damaged or soaked through. At that point, wash and sanitize your hands again, and then put your cloth mask back on until you may have to put on a medical mask again. We're using the N95s just for procedures that create a lot of aerosol, and so that's things like nebulizers, intubation, other sort of scoping, and we're trying to do those not at all in the clinics. That's not necessary. N95s are not necessary just for collecting samples. So putting on the PPE, and bear with me through this. Step one, just wash your hands, sanitize your hands well. First step, placing eye protection. Second step is placing the face mask on. Fourth step, gowns, generally the paper gowns that we're using for this, or the those yellow cloth gowns. Make sure it covers your wrists, so usually just put your thumbs right through the gown to make sure it goes all the way down onto the hands, and then gloves to your wrist. We've been having, both in the emergency room and in the urgent care, sort of a buddy system where somebody just sort of checks you out before you go into the room. And that's actually been quite useful, especially the first couple of times that you're getting ready to see these patients. Taking them off, start breaking the ties on the gown. You're going to do this in the room, either after the patient has left or if you're leaving the room and leaving the patient in there. Then just cross your arms over your chest, pull the gown off, and you'll be able to wrap it up with the gloves inside and discard that in the room. You'll then wash and sanitize your hands. After that, remove your mask, discard, clean your hands again, and then lastly, remove eye protection, cleaning that and storing it for future use. We'll get this talk posted. This is a terrific video, just brings you through it all to remind you. There's also the Mobile MD app, which has been around for a while, kind of, I don't know, just with phone numbers. There's now a whole bunch of COVID information on there, including all the processes for PPE donning and doffing. So absolutely download that, check it out. We consider Agile sort of the source of truth and not Mobile MD, but Mobile MD is great for current policies. Okay, so if that's PPE, this is moving into the EPIC tools. And so these are the tools that are useful if you end up seeing a patient with an influenza-like illness. So Agile MD has the most up-to-date algorithms. They are changed sometimes more than daily, and it really should be kind of your source of truth. There are also these now express lanes in the smart sets in the order section of EPIC, which are pretty terrific, allowing you to efficiently and accurately document. Also allows you to print appropriate patient handouts, prescriptions, forms, everything directly from there. So it makes these visits much more efficient than they have been. I'll take you through what this all looks like. So this is maybe just an epic screen seeing a patient. Your agile pathways are over here. If you click on pathways and put in COVID, you'll see all the COVID pathways. And then under smart sets, if you put in COVID in the search form, you'll get a list of the current express lane pathways. And the one I'll be sort of showing you is this, is flu-like symptoms, COVID-19 screening express lane. And that'll allow you to access what you need if you're seeing a patient in the outpatient setting who's ill. When you open this up, you will just click right here. This opens the express lane. And when you add a note, I'll show you this in a minute, you'll see a pre-formatted note that you're able to just F2 through and fill out an entire note for the patient. The express lane also prompts you to open up the agile pathways, and you get the appropriate agile pathway for the express lane you are in to walk you through the visit. Agile, I think we're probably all pretty experienced with Agile now. All the most recent information comes up first, and then Agile is mostly laid out with algorithms. So this is the algorithm for an outpatient visit. Really nice, takes you through the questions that you'll need to ask. Hyperlinked, so if there's anything that you sort of say, well, what do we mean by ILI? You can click that, you'll get a list of symptoms, and this changes as we've actually added more and more things on as the data for what COVID is presenting like has changed. Agile also allows you to order directly through here, and this is actually probably the easiest way for patients who you're seeing to order the appropriate testing, whether it's going to be a nasopharyngeal swab for a respiratory panel and COVID, or just a nasal swab for COVID. And I'll get to that in a few minutes. The notes look like this. Again, a very simple note that allows you to F2 through the entire note, just filling out what needs to be filled out. And so you really have to not worry about documentation at all. At the very end, when you're done with the visit, you will complete this smart set. And what's pretty wonderful about this is that not only will it allow you to finish your note, finish your billing, and make sure that everything's done, but all of the potential patient instructions will come up. And you can unclick these if need be, and you can click them to look at them yourself. They're really well done, and it gives you directions to hand to the patient to say, okay, are you someone who's going to be isolated at home? Or are you someone who's going to be quarantined at home? What you need to know to manage this illness at home. We in urgent care have mostly been printing those up in the back, so we can just hand those directly to the patient and have the patient, leave directly out. They can also be printed with the discharge information, and we've been calling our coordinators to say, so-and-so is being sent out, please print the information so it can just be handed to her as she leaves, so the patient does not have to stop in the waiting room. At the end, you refresh your note, sign the encounter, and the entire thing is done. So what is the coronavirus? Enveloped single-stranded RNA virus. We deal with these all the time. They're kind of a common, winter cause of colds and upper respiratory tract infections. Over the last 20 years, we've dealt with a couple of new coronaviruses, SARS, which is about 20 years ago, actually, and then the Middle East Respiratory Syndrome. Our newest one, SARS-CoV-2, as you know, started up in Wuhan at the end of 2019. Presentation is really as an influenza-like illness. The earliest data on the presentation was from patients hospitalized in Wuhan, and this is what it looks like. It is clear that this is what the sickest patients look like, because this is a pretty pre-selected sample. But overwhelmingly, the patients who are sick have fever, dry cough, about a third with myalgia and dyspnea, And about a quarter, but probably more in the population, we've been seeing with a pretty severe sore throat, especially as an early symptom. There's a lot of GI distress. First billed as diarrhea, but we're really seeing more in the way of just sort of vague abdominal completes, anorexia, often, often hard to differentiate from the anxiety GI complaints that most people are having. Probably heard anosmia is actually very common and a very sort of early symptom of this. And then not reported early on, actually, the initial data said that upper respiratory congestion, sinusitis, was actually a negative predictor. That has certainly not been borne out here. And we've been seeing a lot of people with just very mild, kind of cold-like symptoms, which turn out to be coronavirus, new coronavirus. What we've been doing in the clinic in an attempt to appropriately treat patients, but also preserve PPE and make sure that we limit exposure to ourselves is when patients come in, we review the vital signs, which we've scaled back to just temperature and pulse ox. We've actually been calling all patients on their cell phones to get a history for ILI before we see the patients. And that's to differentiate the person who maybe has come in for follow-up from their diabetes, and only 5-10 minutes into the visit do they start telling you about their influenza-like illness. We've had to knock on some doors to tell people to pick up their phones, but this has actually worked quite well. If the patient then reports influenza-like illness, then we default into that agile pathway. The ILI history, all outlined on Agile, these are the things that we're most interested in right now. Because of our testing supplies, important to figure out, does this person work in healthcare at UC Medicine who are testing? Rest of the questions you can read along here, mostly just risk stratifying. Bullet 4 here, the people who we're probably going to end up admitting. History of chronic conditions, given that these are patients who you'll probably already have some knowledge of, and an epic chart, you'll probably know all this already. And then lastly, immunosuppression or issues which will be important as far as discharge. Does this patient live somewhere where we'd be concerned about sending them if they need to isolate or quarantine? There are 2 testing options now. Agile does a nice job at walking you through what's appropriate. We have the routine batch testing that we're generally getting results, in about 8 hours. And then we have a rapid test, which is fast, kind of 30 minutes to 3 hours. That's being used for patients who are being admitted, patients who are being discharged from the ED, but we have to think about placement or dialysis, and it's being used on labor and delivery. So we're limiting to those to the situations where it's really important to have a result, which will change management. Again, figuring out which you use is guided on the pathway. If you're doing the COVID and RVP or influenza RSV panel, that needs to be done with a nasopharyngeal swab. That goes in the regular viral transport medium we've used forever. That's the little red vial of solution. We've just end of last week switched to for COVID-19 only using just a nasal swab, much easier, much faster to do. Nasopharyngeal swabs, directions well laid out again on Agile. Again, this does not require an N95 mask, just a regular medical surgical mask works well for this. If you're collecting just a nasal sample, it's just a swab into the nose. You sort of push it up until you hit a little bit of resistance. Rather than going back, you can go straight up. Rotate the swab 2 or 3 times, hold it there for 5 or 10 seconds so you get good saturation of the swab. and then switch to the other side. And then that goes in the Amy's transport medium. In the room, if you've determined that a patient has influenza-like symptoms, absolutely limit to one provider in the room. That person should have full PPE. Go a little bit further with vital signs. If there's fever, tachycardia, hypoxia, getting blood pressure, if the patient appears ill, lung exam, using a yellow stethoscope or a stethoscope that you'll clean, and do sample collection if indicated. Talked about the handouts for those patients if they're going to leave. On the agile pathway or supportive care for those people who get discharged home, all straightforward stuff we're used to. Analgesia and antipyretics. Acetaminophen seems to be preferred. People early on who got ibuprofen had worse outcomes. I'm sure that's sort of terrible confounded data, but we're trying to go with acetaminophen more than anything. Cough suppressant, frequently necessary. Some patients with nausea and vomiting, we've really been seeing more just anorexia rather than nausea. That's been less of a problem. Some people really have needed treatment for diarrhea. It can be that much of a problem. So really a lot of this looks like an atypical pneumonia and the symptoms that we expect with that. For patients with asthma and COPD, it is very clear that patients who are on prednisone do worse with the disease, and therefore we're trying our best to limit prednisone use unless it's absolutely necessary. So just using bronchodilators. If someone really does need prednisone, then 40 milligrams a day for 5 days is appropriate. Patients within 48 hours of symptoms, we're still giving Tamiflu to, though honestly, influenza A has really waned at this point. People you'd consider for admissions, obviously sort of what it's always been. It's really mostly people who are hypoxic or people who are at very high risk for complications, as you'll see here. As the utilization gets higher, clearly the threshold for admitting the non-hypoxic people will probably climb, but we'll keep an eye on that. Other disposition considerations, we have had to think a lot about where people are going if they're going to be sent home, and social work has been terrific for this. There's this pager 30066, which has been super helpful for patients who are living in shelters or subacute nursing facilities. What happens to the patients who get admitted? Just about done. It's really mostly supportive care. Oxygen, fluids, imaging. CT is probably preferable just because at least early on, most of the infiltrates are peripheral, hard to see on chest x-ray, and it turns out the CT scanner is easier to clean than the chest x-ray equipment. Lab tests that indicate severe disease are not really at all surprising. All the things that we usually expect as predictors of severe disease. You can get a myocarditis with this, which probably equates to why the elevated troponin is such a risk factor. And a lot of the sickest patients get at least mild DIC, explaining the D-dimer. What we're doing as far as treatment, so remdesivir is a broad spectrum antiviral. We know it has in vitro activity against SARS-CoV-2, and it does have activity in animal models against the earlier SARS and MERS. Patients are being randomized in a study for that, or actually multiple studies, when they come in. If they're not eligible for remdesivir, patients who can tolerate it and don't have contraindications may get either Plaquenil, hydroxychloroquine, or lopinavir, ritonavir. You see the indications for those below. Other treatments, IL-6 inhibitor for the critically ill patients. Those are really just patients in the ICU. We're using a lot of empiric antibiotics. guided somewhat by the RVP. A very low threshold for prophylactic or therapeutic anticoagulation. This is a little bit controversial, but as we're following D-dimers on these patients, there's some suggestion that those with high D-dimers benefit from anticoagulation. And then corticosteroids, again, only in the sickest patients beginning to show shock in the ICU. This is sort of the disease course, which really at this point has been quite well described. So the vast majority of people, around 80%, go through this early stage and are mostly better by about 8 to 10 days. Lots of people with even, shorter, less symptomatic courses. The patients who become sicker, and most of the people who we're seeing in the hospital, fall into this group where they're having a pneumonia, which can be sort of mild or moderate. Those people need supportive care, need oxygen. And then this fortunately smallest percentage, but the sickest patients go into the real kind of cytokine storm inflammatory response phase. And those are the people who are ending up in the intensive care unit, often ending up ventilated. ICU criteria, not at all surprising, the things that you'd expect for, that we'd always send people to the ICU for. The progression to intubation, this is from the initial data. We've actually been seeing less of the really rapid deterioration and more just sort of a slow progression to greater and greater hypoxia. Median time from symptom onset to ICU transfer is about 10 days, and that goes along well with this graph. Additional resources, so the COVID Resource Center on the intranet has kind of all the up-to-date information, and the staff resources here, both the phone number and the pager, have been amazing. I've used them a couple of times, figuring out triage of patients, and they're just doing an amazing job. Right now, this talk lives on the medicine website. We'll make sure it gets out to you guys too, but easy to find. So I'll stop there and answer any questions that I can.
Great, we have a few that came in. The first is kind of a clinical volume question. Have you been able to see as many patients using the Agile MD tools as you could prior to COVID-19? And if not, what percentage of the previous volume are you seeing?
It's a good question. So, I mean, like I think all of us, I mean, my life has changed ridiculously. I've been doing my clinics, almost completely online with the express lane, which is certainly not adequate. We've been doing great as far as the COVID screening with lots of volunteers. Those visits are incredibly fast. They're sort of, 5 to 10 minutes to just scroll through people's questions, seldom needing to actually communicate verbally with the patient. And we've been limited only by our supplies in testing. And I'll click through this, which is our present testing algorithm. I think this is the most up-to-date one. Yeah, has really changed continuously depending on what the supplies we have are. Right now, we're doing okay with supplies, and so the people in this yellow group who we're testing now is a little bit broader than it has been in the past. We've gone through times where we've only been testing healthcare workers, and this now includes actually patients just over 50 as a comorbid condition. It pains me to say that.
Great. Are there cardiac manifestations of the virus?
So in the sickest patients, yes, we're seeing increased troponins, which probably go along with myocarditis, and those are the patients, that's a predictor of the worst outcomes. not surprisingly, it's also the patients with underlying illnesses, hypertension, diabetes, and cardiovascular disease also seem to do the worst. So it seems to be, almost a perfect storm for those patients.
Got it. What do we do with healthcare workers from other institutions who present to our ER or clinic?
So that's also, sort of changed over time. Right now, those people do fall into people we're testing. And so if we see someone who's a healthcare worker, someone else who comes in with influenza-like illness symptoms, we are testing them and then treating them like everybody else, that we would send them home on isolation until we have results back and then make decisions based on that. We've also been aggressive at telling people to, use their own hospital's guidelines as far as returning back to work to try to decrease confusion.
Got it. 2 questions about the sensitivity and specificity of the 2 tests. And I might add to that, what are you doing with people who are presenting with all the symptoms but are testing negative because the sensitivity might be a little low?
Right. So there's no question that the sensitivity is as low as 70%. Probably actually better than that in practice, but nowhere near 100%. So on inpatients, we're testing people twice. If they're high clinical suspicion, first test negative, which we think is getting sensitivities up at least into the high 80s. For other patients who have influenza-like illness symptoms, but have a negative test, say in drive-through, honestly, those people, we're sort of telling the same thing, that they should isolate until they are better for 72 hours. And then at that point, can go back out, but should absolutely be wearing a mask at that point.
Great. If patients are randomized not to receive remdesivir, are they eligible to receive Plaquenil?
I don't know. I don't think so, but I'm not sure.
Okay. Can you elaborate on why a patient would need anticoagulation?
Yeah, so there's some data from China that's non-randomized data that took people early on in the pre-ICU course who had high D-dimers and then treated those people. They were mostly actually treated with prophylactic anticoagulation, which most of these people qualify for anyway, and those people did better. So it's not clear if what was just happening is the checking D-dimer was selecting a group to basically get standard of care, and that's why they did better, or if it actually was beneficial. And so what's happening here is mostly patients with very high D-dimers who are very sick are getting anticoagulation as sort of a treatment for DIC. But the data on that is very poor, and that's one of those places that I think we're just sort of reaching for what we can do for the sickest patients.
Is rhabdomyolysis a complication of HCQ?
I'm not sure about that. Not something I've heard a lot about and not something I've seen.
Can you speak about recovery efforts after the peak of the epidemic and the strategy after regarding clinic visits and precautions?
I think I'll pass on that. I don't know. I think it's going to be very complicated, right, how we unwind from all this. And we talked a little bit about the beginning is that, I think it'll happen slowly, and it'll be what we're all, ready for. And it'll I think, there'll be a little bit of effect of what our patients will be ready for, right? When people start feeling comfortable coming back to us. Right now, the hospital seems like a very safe place since there's nobody here, but we'll see.
Sure. So there was a lot of initial enthusiasm for hydroxychloroquine, but a lot of available evidence now seems anecdotal and dubious. So Darren says he might have missed it in your talk, but are we now getting away from using it outside of RCTs as shortages appear? Or how has your protocol changed?
Yes, we are. You're right. I mean, the data behind it is just terrible, awful. Terrible studies, terrible endpoints, nothing really clearly supportive. And so right now, as you see in the slides, in people who are sick and can tolerate it well, and are not in a study, we're using it as, oh, here's something we can do. There are multiple studies. There's a very good one out of University of Minnesota right now for exposed healthcare workers, which is a RCT, which has enrolled many patients. And so certainly there's no evidence for using that as prophylaxis in exposed people or people who are well or people with very mild symptoms of disease as treatment.
So does anything characterize the unexpected severe cases? So for instance, young and otherwise healthy patients that rapidly progress to ventilator dependence and life-threatening disease?
There's not really. Most of the lab tests that I pointed out are probably the best that we can do. But I think what the questioner probably is getting at is that, younger person who's well and seems to have just an influenza-like illness, are we able to distinguish those people who are just going to, ride it out at home for 5 days, sort of feeling crappy, or the patients who are going to end up hospitalized with a viral pneumonia? And at that stage, we don't have a good sense of that. Because we're certainly not, doing all these labs on everybody who just seems to have the flu.
How many of the ILI symptoms should the patient have to test? What about only fever, only diarrhea?
So if you go to this chart, which hopefully you can see the whole thing. So low risk patients are sort of the non-healthcare workers less than 60 with any of the ILI symptoms but no red flags. And those people were really not testing, we're just isolating those people. The people who we are testing, other than healthcare workers, are older people with some risk factors, some reason that we'd be interested in testing. Over here, the red flag people are clearly the people who we're worried about. And the people who get into that group are mostly pulmonary symptoms.
When would it be safe to bring patients who are either COVID plus or positive or suspected to have COVID back to clinic for issues that are slightly urgent, but not urgent enough to come right away?
Right, so we right now are using the 4th floor of the DCAM as a COVID area for those patients. And it just takes a lot of judgment. I've been amazed at how many things that I used to think were necessary that I've been able to totally do without with people. But if someone really needs to be seen for something, we absolutely have the capability now of doing that. Patients are coming in the east entrance of the DCAM, are met there, are masked, go up those east elevators, and so they're sort of segregated the entire way through.
So in your opinion, subjectively, are we doing the best we can to protect our healthcare workers within our institution?
In my opinion, I actually think we've done a terrific job. I sound like I'm advertising, but I feel like the place has done great. Supporting our healthcare workers. It's been really hard keeping, the place stocked with PPE. but we've been able to do that, changing, what masks we have at what time by necessity. But I've sort of been proud of the institution, and I say that not as in leadership, but as a clinician,
Great.
mostly watching rather than treating, I gotta say.
Are we seeing a significant number of patients that we are concerned might be acquiring COVID in the hospital, like they're admitted for some other reason and then develop it?
I don't think we are.
Good. Any idea when antibody testing for prior infection will be available and if it would be useful? Is it being studied here?
Yeah, I don't know. I've sort of thought a lot about and started reading about, how we unwind all this stuff. And antibody testing will be very interesting. I think it sounds like the hope is among people who really know what they're doing is that, we have, if you think about, the size of the city and the number of infections we're dealing with, we have, fortunately, this remains pretty rare. And so we're hoping to not get through this by having herd immunity, but by, suppressing the virus. But certainly it'll be super interesting seeing that. And the early data really does show the exact sort of antibody production that we expect after any sort of viral illness, in the usual path with the antibody shifting from IgM to IgG over time.
Adam, are you okay for another 5 or 7 questions? Or
Sure.
are you okay on time? Good. We're really, really grateful to you for doing this. All right,
Yeah.
Keep going, Rebecca.
Great. Someone has read that people still shed the virus for 20 or more days. How long can you remain infectious after your symptoms have resolved?
Yeah, we don't know that. I mean, it seems, and what we've been recommending for people has changed over time. It seems like the safest recommendations, accounting for sort of the most people, are to say, absolutely wait until you are symptom-free for 72 hours. And then at that point, still keep up with the social isolation that we're all doing and absolutely wear a cloth mask. The effect of suppressing, respiratory droplets from an infected patient with a cloth mask is enormous, and actually seems more effective for COVID than it does for flu or rhinovirus. So, cloth masks don't do a whole lot does something, but not a whole lot for protecting us from the illness, but does an enormous job at keeping a patient from spreading it.
For the recommendation regarding the type of mask used while seeing COVID or ILI patients, earlier the CDC said that surgical masks aren't good enough, the virus can go through them. So how good is the scientific evidence regarding surgical mask recommendation when seeing COVID patients?
Yeah, I think it's okay. If there is really significant, respiratory droplets aerosolized, which happen certainly, in a hospital room, especially not a non-negative pressure hospital room, would make a surgical mask not terribly efficient. But for seeing patients who are, not sitting in a room, coughing, sneezing, not having aerosolized procedures like nebulizer treatments, we've been doing this now for, a number of weeks and haven't seen, infection in any of us who have been using surgical masks to see those patients. So they are certainly not as good as an N95 mask, but they certainly used in the right patients, in the right setting, in the right way, seem to be adequate.
Great. We had 7 residents and faculty recently test positive for influenza A in the last 3 weeks. Is there any information on risk of subsequent COVID infection?
I don't think so. I certainly don't know if there is. We were amazed up until about 2 weeks ago because we never test people, we never do RVPs in these people. And the amount of influenza A and metapneumovirus, that we were seeing in people was just astounding. And it's just because a lot of the things that we usually say, you're fine, turn out to be diagnosable if we do. And I don't know if that increases your risk for COVID.
What's the recovery rate at our institution for patients who are intubated?
I do not have that data. I know we've had, a bunch of successes of people who've, been extubated and sent back out to the floor, but I have no idea what the actual rate is.
Okay. Risk of ACE inhibitors on COVID patients?
Yeah, a total, theoretical, bioplausible, who knows? The idea is that ACE inhibitors maybe upregulate the ACE receptor, which is how COVID, gets into us. And certainly there seems to be worse outcomes among people on ACE inhibitors, but those are the people who are at higher risk anyway, and we don't have the sort of data to tease things out. So I don't know.
Sure. How convincing is the data on the protective effect of being blood type O?
That I think is garbage. I've had a bunch of patients reach out to me and say, "What's my blood type?" And I'm like, "I don't know your blood type." From what I've seen, that's terrible based on tiny numbers and very much a sort of catch as catch can, convenient sample. Whatever, it may turn out to be something, but I think at this point we don't know.
Sure. How busy has our COVID clinic in DCAM been?
I would think it's been ratcheting up. It's a little hard to tell because we keep on shifting patients around. The other clinic we have is we've got the ER, 1.5, which is seeing kind of the less sick influenza-like illnesses. And so that's been taking a lot of the pressure off a lot of these other locations. We have seen a big fall off in the demand for testing in the last couple of days that we're hoping is an early sign of good things to come, but
Sure. Related to an earlier question, do we have healthcare workers getting sick at work? And if so, how many?
I don't know. I think we've done pretty well, but I don't know.
Surprisingly few.
Is that right? Good.
Can you highlight any info about pediatric cases?
Oh, I don't. I think what I would say is what we all know is that the experience so far in kids has been remarkably mild disease. There are certainly some kids, some infants who've gotten sick, but the concern is as we unwind these that a lot of kids who are prone to infections like this may have very mild symptoms, and that'll be a challenge to how we get out of the isolation side of it all.
Sure. When COVID positive patients become non-contagious, can we have them come back to the regular clinic in the DCAM and not the COVID clinic?
I'm not sure if we have guidelines on that yet. There were CDC guidelines from about a week ago, week and a half ago, which began to pitch the, once you're recovered, do we still need to use PPE on you? So I don't know. And I think as we get further along, I'll be looking to leadership for that, for, how we manage patients who've been sick. I think right now the caution and what we know about how good masking is for sick people is to just err on the side of caution and have those people masked whenever they come back.
This is just a nice note. Can you please let all our medicine colleagues who are on the front lines know how much we surgeons appreciate them?
Well, thanks. Will do.
I know you may have answered this, but your thoughts on universal masking for patients and visitors?
Yeah, I
Yes.
think they should be universally masked. That is a good recommendation.
Right. And again, we may have touched on this, but if a healthcare worker is recovered from COVID, do they need to wear N95s given their likely immunity? So a little different.
Right. Right. So my understanding is right now, once healthcare workers have recovered, we are still recommending full PPE on them, but that might change.
I would add to that, and this is just my own question, are we seeing the virus mutate at all?
No, there's been no evidence of that at all. And that's from mostly data from Italy. There was concern that, oh, are we seeing something different? Are we seeing, worse outcomes now? And it seems like we're dealing with the exact same virus that this started out on multiple samples. And the variation in outcome has depend on testing, reporting populations, and not on a change in the virus.
And how long would immunity last for?
Oh. Yeah, we have 3 more short questions, and then I think we'll
wrap up. Sure. Any role for tracheostomy in patients with COVID who have prolonged intubation but are making improvements?
I don't know. I can't answer that.
Why do African Americans have such a high mortality?
Yeah, I think we're all trying to figure that out. I mean, I think it's probably somewhat a marker of underlying disease, somewhat a marker of healthcare disparities, and whether it's something biological as well, I have no idea.
There's an article in the New York Times about that today if you want to read more.
Yeah. And a terrific editorial actually in the Tribune by Monica Peake today that you should take a look at.
Have you seen any patients that have recovered from COVID and gotten sick again?
No, I have not. Though obviously my experience and numbers are small. My personal patients who I've seen through all of this have all done well and have been fine since they've kind of gone back to work. But
Adam, I want to thank you so much for spending this hour with us. It's been incredibly enlightening. I'm going to read to you the question, or really the comment from John Alberti that says, "Thank you so much for doing this. It's been useful. You are a fountain of knowledge and a voice of equanimity in a complex and frightening disease." And I think we all share that sentiment. We're really grateful for the work that you and your colleagues are doing, not only in caring for the patients, but to help educate us and often to help our own concerns and anxieties about being a healthcare worker in this environment. So thank you very much for this. We'll get the presentation out. I guess we'll get that link to people, and we record this so it'll be available for people who missed it. Again, thank you very much, and we'll let you go now. Thanks, Adam.
Thanks. Appreciate it for having me.
Mm-hmm.